So we're here today with Eric van der Hijden. Thank you. I wanted to see if you could introduce us to yourself and your organization, talk a little about your education background and how you got into this value-based arena.
Well, nice meeting you and having this conversation. Well, I work at Zilveren Kruis. Zilveren Kruis is the largest health insurance company in the Netherlands. We have about 5 million members. In Zilveren Kruis, I work at the strategy department where all the procurement of healthcare providers is done. And within that strategy department, I'm part of the management team and I'm responsible for alternative payment and what we call integral contracting. So traditionally you contract a GP, you contract a hospital or a paramedics, but how do you combine this contracting? What kind of payment models do you use in that case? To give you an example, our strategy unit is about 90 people, having business analysts, medical specialists, people from policy experience, legal, and they all work on contracting.
So as we get into alternative payments,
yes,
it's this nice, simple sounding word that can mean a lot of different things. So can you tell me, how do you and Zilveren Kruis define alternative payment, and how does that play out in your world?
Well, alternative payment is sort of everything and nothing at the same time. Alternative payment is like sort of the magic solution. It's a sort of statement that solves all the problems. And the issue is that you have to be very specific on what kind of problems you want to solve. I'll try to make an example. Fee-for-service in some contexts works really good. We have now COVID, and if you want to stimulate that people get vaccines and you would pay a GP for every vaccine they give, well, fee-for-service has a very tremendous effect because you stimulate volume and you want volume. So it is naive to say that fee-for-service as such is always a bad thing. The general effect of fee-for-service and the way it is set in the culture and the way organizations work, that's a problem. Because organizations, because of this model, are volume-based. The whole internal budgeting is based on it. Every staff member in the hospital have personal targets on how many patients they see, how many procedures they do, and that's the problem. So it is the volume incentive that creates a lot of problems we don't want. So, but you then still have to define what are those problems. And we see a number of problems. The first one is that traditional fee-for-service contracting doesn't stimulate innovation, because if you want a new type of care and it's not billable, they won't do it. The second one is that an integrated approach to a patient is not stimulated because all the different aspects or the different treatments are billable, but the care part as a whole is not billable. And there are always elements in the care part that are not, they don't have a legal code you can use to send a bill. Those are barriers to optimize those whole care processes. That's the second one. And the third problem is if you want to cross domains between healthcare and, say, social care or long-term care. These are in the Netherlands different financial structures with different payers, with different incentives, and it's very difficult to cross those borders. So what we do is to find the smallest possible step beyond fee-for-service on those three areas. So if you want to stimulate innovation, we are very much alternative payment for us means creating new billable codes to stimulate innovation. If you want integrated care, then the real alternative payment models come up, mainly bundled payment, because you completely different incentivize providers in those models. And in the third context, where you want to cross borders, there we have other models. What we there try to do is to align at the strategic level our procurement strategy with the strategy of the long-term care and create circumstances for patients to have better care. But it is a different approach to alternative payment models. It's more combined contracting, combined commissioning. It's a different approach. But bundles are the most challenging because you completely rearrange the scene for providers to work. And we have good results with them. We also have some problems, but we also have good results with them.
But pretty exciting. It sounds like at Silver Cross you've done a lot of different experimentation with alternative models in a lot of different settings across the continuum of care. Can you pick the one, or maybe one of the ones that you're most excited about or that's been most successful, that we could really focus and drill in on that one today?
Our most successful alternative payment models are in primary care. And the key structure of those models is that we use them for cardiovascular disease and for pulmonary disease. You have the whole chain of care. If cardiovascular disease is not managed well, people may be hospitalized or have medication. And what we do is we pay the GP at a population level to stimulate prevention and early detection of high-risk patients. And we reward them for lowering the integral costs and increasing quality for those two patient journeys. And we've done them now for one is for 7 years and one is for 4 years. And we have very good results. We see the total cost going down. We even see the incidence of people with pulmonary disease going down. And because there is no incentive to be ill, and normally you only get paid for pulmonary disease if you have the diagnosis. But if you pay for preventing pulmonary disease, you even see the incidence down.
So what you wanted to talk about the general practitioners and focusing on heart disease, pulmonary. Was there a problem in the country or at Silver Cross where you chose that? How did you choose what problem to solve?
Oh, that's a good question. We started our alternative payment program about 7 years ago. And it was the moment where value-based healthcare was really getting on track. Everybody was talking about it, and everybody was talking about, well, what's the role of the healthcare insurance company? So we said we're going to start a program where we want to experiment and learn what our role is and what alternative payment means and how we manage it in our claims processing architecture. And then when we started, there were, I think, 30 or 40 projects that said, well, pick us, we want to do a project with Silver Cross. So what we did was we chose contrasting projects, not based on financial potential or based on quality issue, but we arranged a group of projects just to have contrast in learning. So those two were primary care groups who already were very patient-centered and very focused on population approaches. But we also choose 3 projects in hospitals, one on HIV. We defined a bundle on HIV. We did one on cardio stroke, which is our most complex bundle, and then one on open heart chirurgy. And we choose them to learn. The open heart procedures was too complex. We put a lot of time in it and we didn't get it working because it was too complex. There was too much money involved and the uncertainty for the hospital was too big, so we had to stop it. The HIV one in the hospital worked very well, but the most spectacular results were in the primary care. And the reason why I think that those alternative payment models worked well is because the patient group involved as a percentage of the total population of the provider is quite high. If you have cardiovascular disease at a GP level, the prevalence is 30%, I don't know, something like that. So a high percent of people in the GP is included in the alternative payment model. If you have a hospital and you do open heart chirurgy and only 0.5% of a department is included in the bundle, it is such a small fraction of the patients they see on a daily basis. It's more theoretical project than an actual day-to-day project where you can learn from. The patient group is so small. And that is one of our key learnings, is that if you want to do alternative payment, you really need to have a substantial group of patients directly identifiable by a healthcare provider to intervene. if the group is too small, you don't get the change you want. And everybody's talking about integrated practice units, but it's a theoretical concept because you can't organize healthcare in first dividing all separate integrated practice units because you had to rearrange all healthcare. It's not possible. You can't separate all those units from their original background. So that's our key lesson. You need to have sufficient volume to get it working.
That makes sense. And I think I see a lot of models focusing, well, we'll do diabetes, heart disease, very prevalent. You talked about pulmonary. Prevalence varies, but that's certainly up there. Interesting you point to HIV. That one's not terribly prevalent,
No.
thankfully, in most societies. How did you decide that was one to pursue, even though the prevalence was low?
Yeah, that is a very good question, because one of the problems with bundled payments is that, well, we call it garbage in, garbage out, is that if you have hip-knee replacement, it's very common to do bundles on that. But the problem with those two is that there is a lot of practice variation on how often you intervene and what your clinical cutoff point is where you intervene. So you see that some hospitals, the chance of being treated are much higher than in other hospitals. And we thought if we do a bundle with those hospitals, you include the over-treatment in the bundle. And we had no experience with how to manage that, and that's why we took HIV, because there is no practice variation on the diagnosis. You have it or you don't have it. And that is why in the experiment we were very glad to do it, because there is absolute no debate on whether a patient is included in the bundle, which is a problem on itself. How do you find a patient you include in a bundle? And there is no debate on whether the person has a disease which you should treat. And therefore you can focus on the integral cost of care and the complete patient journey and outcome. And I'm really glad we did that, because one of the lessons we learned is that the first step, if you want to do a bundle, is make sure that the provider has an acceptable range of treatment. If you have someone who's over-treating, never start a bundle, because you keep the over-treatment in the bundle and you sub-optimize and you pay too much savings because, well, I'm going to really into the technical details now, but if you have a hospital which has a lot of patients and they over-treat and you want to lower costs and improve quality, the first thing they will do is stop treating after they close the contract, and you will pay too much savings because you included too many patients into it. But that's very technical now.
Well, actually, that's the direction I wanted to go, is how do you build this to do it right? It sounds like what you're flagging, anybody who follows in your footsteps needs to watch. What's the baseline of procedure activity?
Yeah, and that's exactly the key point, is that alternative payments should enable providers with the current budget to do better for the patient. Everybody's talking about triple aim. We always talk about quadruple aim. The staff, their work quality, if they enjoy their work for us, even as the same level of relevance. So if you have a provider that says, listen, we are very conservative in our treatment. We only treat if there is a clinical relevance, and we know that from data. But they say the fee-for-service model limits us in flexibility, and to rearrange our organization and to work more integral and to innovate, then a bundled payment adds value. Because then you say you have one price for the whole patient journey, and we stimulate you to step out of your traditional footsteps, the way you work, and look at a more innovative way on giving patient care. But if you have a provider that is over-treating, you sort of incentivize them to keep over-treating. So you must be very accurate on when you use bundles. Using it in general and saying we skip fee-for-service and go directly to bundled payment is with a lot of risk and a lot of technical issues implementing.
I want to spend a little more time on the hip and knee bundle, for example. why does it necessarily, by bundling that payment, why does that necessarily mean you'll continue to get too much volume? Are there prior authorizations or some kind of criteria before the procedure would be permitted in the first place?
Well, I think that depends on the system characteristics where you're talking about. In the Netherlands, we have no prioritization for hip knee surgery. Each hospital has their own, well, they are able to make their own decisions on that. What we do is with a lot of analysis on practice variation, look at what is the optimum level. That's one part. So you try to look at what is the reasonable level of treatment. Once you have a bundle, you get a different incentive. If you have a bundle where you reward for quality, the incentive will be to include as less complex patients as possible, because your outcome will increase. And this is a problem because, and we saw it at some points, and you now see literature on it in the international research. If you have a level of quality and you want to maintain that level or improve it to get a higher part of your shared savings, you see that the catchment area of those organizations grow because they are looking, and I'm not saying that people are frauding, but it is a mechanism that will increase, that they are looking for patients from other regions to have patients who, with the highest chance of good outcome, will include, so they raise their quality level. One of the control mechanisms we do is that we define the catchment area of the hospital when we start a bundle. So we say all the patients with that procedure in your catchment area is included in your bundle, apart from the fact if you treat them or not. And if you have, say, Amsterdam, and you have one hospital, and a very complex patient will be treated in another region, that could be done by the hospital to lower the risks of complication and increase the chance of savings. And that is why we include it in the contract of that hospital to say, even you didn't treat that patient, it was in your catchment area, we still take it into account for your savings and your quality measures. They didn't like it, the hospitals, but they now see the reason why we do it, and they feel more obliged to also take care of those more complex patients.
What about risk adjustment? A lot of people would simply argue for risk adjustment to compensate for that.
The problem with risk adjustment is that we had a lot of discussions about risk adjustment with both hospitals and doctors. And if risk adjustment, of course you need it, but because risk adjustment calculations are very complex and sometimes very unclear from a clinical perspective, risk avoidance still takes place. So you can do a risk adjustment, but that doesn't mean, because doctors don't understand if patients come to them, whether there is a chance they have a high saving or not on that patient. Even if you have complex risk adjustment mechanism, you still have the fear of, is it a profitable client? And I'm putting it very black and white now. What we learned is that if you do risk adjustment, you should do it on characteristics a doctor can see and understand. So if you do risk adjustment where you say you get a higher price if someone was acute hospitalized in the year before, they can see it in the medical records, and then they know, okay, I get a higher price for this patient, and now I know what my position is. If you do it only on statistical grounds, not transparent for a doctor, you don't solve this behavior at the front gate. That's our experience.
Wanted to get a little clarification. So on your bundles, it sounds like they're population oriented, because you talked about shared savings being related to the market footprint or the service area, and you talked about it for the population. Most of the bundles I've seen have been individual patient oriented and not related to a population. Can you explain a little more clarity on the bundle and how the population plays in versus just one patient at a time?
Yeah, this is a very relevant difference. I have to put it in 3 blocks. The population bundles we have are in primary care only. Because if you have a GP and the GP has, say, 3,000 patients, reward them for the average cost of medical expenses for cardiovascular care for the whole population. So not only for the patients, but for the whole population. And the reason why we do that, if you would reward them for the average cost for a patient, you would stimulate labeling people as patient because you get more money. And you wouldn't stimulate prevention because it is very difficult once someone has cardiovascular disease to dramatically lower the cost. So we say we divide those costs over the total population and lower that, which makes them more looking for patients in the early stage. So that's only population-based.
And I'm sorry to interrupt. So then in that GP perspective, that would include all conditions, all total cost of care?
No, only cardiovascular. So we look for all patients for defined list of DRG codes, medicine codes. Those are strictly defined. We defined the bundle together with doctors, which creates lists of hundreds of medications and billing codes. And for those specified group, we look at the cost of the total population. In the hospitals comes the point you address. Do you pay for an individual patient, or do you pay for the total population of that hospital? The reason why we explicitly choose not to pay for an individual patient is then you have two problems. You have the problem of the risk adjustment, because then you need to risk adjust, and you have the problem that you don't take into account the volume of patients in that hospital. I'll try to explain. If you have hip and knee surgery and you have two hospitals, one has 30 procedures a year and one has 500 procedures a year, the ability to influence costs and quality in the one with 500 is much bigger than in the one in 30. That is why we don't use risk adjustment, because we don't pay separately for one of those 30 in those hospitals. We say, no, we take the average costs of those 500 index year and take that as a level, because then you include all the patient characteristics and you have your case mix adjustment. So we have minimum volumes for bundles. In general, we say don't start a bundle if you have at least 250 patients. Otherwise, you get very complex case mix adjustment calculations. You stimulate value at a much too low level of treatments in a hospital. We know that quality and volume is related. So don't try to stimulate volume in a hospital, which by definition has a too low number of procedures to have quality at all.
Now, does this work better in a metro area or a service area where you only have one hospital and so they're getting all the volume for cardiac, let's say?
Yeah.
Or is there a different dynamic if you have three hospitals that in essence compete with each other in that same area and they're each trying to get the Silver Cross cardiac volume? Does that change the dynamic?
We are in sort of point where this comes into stake. The bundles we have are still separate hospitals and GP groups spread over the Netherlands. We are now at the point of scaling up. And we are exactly in the middle of this decision. What do we do? Do we first give all those hospital bundle contracts and then see how patient streams go, and whether they all go to one hospital or they go to another hospital, because then you get a higher volume, and let the market do the competition? Or do we first make at a regional level agreements with hospitals who will specialize on which patient group? If we're now in Amsterdam, we have a number of hospitals here, and we are in the middle of this discussion with those hospitals. Who is going to focus on cardiac? Who is going to focus on oncology? Because if you rearrange the market to create more volume, the travel distances are almost similar if you go to one hospital or the other, But if you have two hospitals giving the same procedure, you never will get the volume and experience to get quality. So we decided first to get more focus in hospitals on which are the patient groups they serve. And then we set the next step on alternative payment within those hospitals to accelerate. That's why we did the HIV contract. The hospital we did the HIV contract with has about 30% of the market share for all HIV patients in the Netherlands. It's more concentrated in the Amsterdam area. They have the largest share. So they have about 2,500 HIV patients, which that volume is so high, we don't need to talk about risk adjustment, because if we have the average historic prices as a reference point, it is already case mix adjusted.
That's great. This is a different way of thinking about bundles than a lot of people when they talk about bundle hip and knee, like in the US. It's my grandmother goes in for surgery, there's a bundle and it's for her.
Yes.
And it starts on this date or when she receives this initiating care, maybe the primary care specialist consult, and it ends after so many days post-surgery or therapy or whatever. So this feels almost like a hybrid between that definition of a bundle and a population.
Yes.
Because what I see you doing is it's a population-based payment, or capitated, I'll say.
Yeah, it's a mixture. Yeah.
Based for a patient type.
Yes.
Like cardiac.
Yes.
And that's exactly why the case of you described, what we try to prevent is that if you define bundles in that way, you're constantly looking for average patients with average cost structures. But we know they don't exist. So if you make it an individual payment and you try to make it risk adjusted, you still have the issue that the bundle is not enough for the care needed for your grandmother. If you say it's an average price, at the year level we middle out. So one is much more complex, one is much more cheaper, but it middles out. You get much more freedom at the care provider, because in your context, they still are incentivized to limit care, because they know if the end of the bundle comes inside, we have to get rid of your grandmother. I'll put it a little bit black and white. But if you say this on all the people with hip and knee in your hospital, and you have the 300 in a year, it's an average price, and you see the floating average every month going up or down, you know, oh, I'm on the green side. And you don't do it at an individual level. That's the big difference.
I wanted to dive into part of what you talked about with having a hospital that you contract with focus on one condition, because one of the next questions I wanted to ask was, who needs to be at the table as you design these bundles? And it sounds like you've got a part of your strategy to try to focus. This is the focus factory idea we read about in the literature, or centers of excellence, that all of the, I'll make something up, hip and knee will take place at this hospital, and maybe all the bypass grafts at this hospital. So can you talk a little bit about, as you built a model, be it the bundle or whichever, who needs to be at the table to build a really solid model? And then also this issue about focusing certain care in certain provider locations.
In the hospital landscape, you have different kind of hospitals. You have academic, you have high specialty, you have more common hospitals, and you have private clinics. And they all have a completely different cost structure and business model. And if you want to create value from a societal perspective, you need to have an idea which kind of patient should be treated in which hospital. If you have the most complex patients, you want them in the academic hospital. If you have a normal hip replacement without any technical issues, if you would do it in an academic hospital, you would pay too much. So there is a long tradition of making agreements between hospitals who is responsible, which level of complexity. So, because you can't manage them all in one bundle, and that's why case mix adjustment is so complex. If you want to manage the full complexity of the range of complexity with case mix adjustment, it's very difficult. So it starts with defining who takes which kind of severity of patients. The second one is, if you say bundles are for stimulating innovation, for stimulating quality, you need to have some centers of excellence to do that. You're not going to do a bundle contract with a provider that only has very limited a number of patients on that. So by making those statements, we try to set the market in movement to that hospitals and especially doctors, and they know they want to do the procedures. And if they know Silver Cross is not giving a contract for this procedure in my hospital, but they're going to give it to the other one, they're going to call and discuss, listen, if I do the procedures over you, with you, those doctors groups are more and more flexible between hospitals, they know they can concentrate and learn. And it's constantly looking for the balance between competition on quality and price, but also make sort of sensible view on the landscape of hospital care, who does what. Once you start defining a bundle, and we've done now I think 8 or 9 of those projects, and we're learning faster and faster how to do it. You do it with doctors on the table. You need the doctors, you need the finance group from the hospital, you need people with knowledge of claims and finance from our side. And what you do is identifying characteristic and look at all the costs involved. So which HIV, the identifying characteristic is people with a lab test that defines they have HIV. So you can define those people in our claims database, pick them out with a stick, and then look at all the costs those people make in average in a year. And then we go in depth with doctors. What's clinical relevant and what is not clinical relevant? What should we include in the bundle or not? And the reason why we do it is that you find all kinds of declarations of care we didn't know that was HIV related. Typical story is that when we did the HIV bundle, we noticed that this group also has a lot of dental care. There is no technical relation between HIV and quality of your teeth. It was a coincidence. But if you would do it on sort of only financial perspective, you would have included it. But there is no, an HIV doctor is not able to influence dental care. So you really sort the pile of costs out until you have one that follows the patient journey. And then you start discussing what are avoidable costs, what are costs you can lower, where do you need more innovation, where you can do it. So it's something you mainly do with doctors.
So you pulled mostly the clinical representatives into the room, had the discussion about what's the clinical path, where can you, use kind of a machine analogy, adjust the knobs to try to improve avoidable utilization, right? Increase important utilization. Okay. What about the business managers or chief operating officers at these organizations? Did they come into the question as well? Because they have a lot of influence over how their organizations operate.
It's a project you do in a number of steps. It first starts on a C-level, whether you do it or not, and what are the general terms. And one issue always is if you work with payment model where you pay a fixed amount of euros for a patient journey on average. One of the questions is how do you index that payment for national trends? Let's say wages are going up. Do you compensate for that? Another issue is medication. If medication falls out of patent and you get more generic medication, well, the bundle price should go down. Well, you start at C-level with this sort of rules of engagement. How do you interact with this price? If you wouldn't correct for wages, you know the hospital will lose money. But if you wouldn't correct for lowering medicine costs, we pay too much. So we start at C-level on those general terms. How does the contract work? And sometimes we don't agree and we fail and we stop because people say we feel it's too uncertain. The projects we did with GPs, we tried to expand them to other regions. And we had a number of GPs, they say we found it too risky to do it. We want certainty in a fee-for-service model. We're not going to do it. So that's, once you reach that agreement, then you engage the clinicians and the doctors and the medical staff to look in depth. You need both levels in that order. If you don't do it in that order, it doesn't work. And now we are on the level that we have a number of those bundles who are solid. We have a lot of experience with data analysis. We have a lot of experience with how do you define and measure quality. And I think next year, maybe year after that, our primary care bundles will be available to all GPs in the Netherlands. They can opt in.
Opt in for all patients or individuals?
No.
All or nothing?
All or nothing, because it is a population bundle. I think the situation that you can opt in at patient level, we will never do that, because we know from all kind of incentives we had in the past, it creates extreme perverse incentives. We will never do that. And I know in the US that's an option. You can opt in at patient level in some circumstances. From a Dutch perspective, we don't understand why you even propose such an option.
I want to take a little while and talk about the focusing on the individual hospitals with certain patient populations. And I'm trying to imagine, again, in my own market, hyper-competitive hospitals. And the idea that one of the major payers would come and say, oh, I'm sorry, we're only giving all of our hip and knee to this hospital. The rest of you are just out of luck. I can't imagine that scenario ever being acceptable. Can you talk me through a little bit about how that concept is playing out? How are there are about 6 hospitals in the Amsterdam area, as I understand. So that example, if you're saying we'll give all our hip and knees to one, how is that acceptable to the others? And is this a peculiarity of the Dutch system that won't apply to anyone else?
No, that's good that you put it back on the table. Well, we're not able to do that. The legislation will forbid us. On the other side, we contract hospitals, but in Dutch legislation, you can also, if a provider works out of network, we have to reimburse about 70% of the traditional fee. So there is always a backdoor for providers. And we see especially new private clinics coming into the market using this backdoor. They are out of network, but they do it for 75%. So we're not able to unilaterally say you get this procedure and the other one gets the other procedure. But there is a big but. Staff shortage is a huge problem, especially in Amsterdam. And especially a specialized staff. For specific procedures, you need specialized staff. So you see, because of that, hospitals are already thinking about, if the staff is the limiting factor to growth, how are you going to organize it and how are you going to do it? So it's not that we can compulsorily say you get this and you get that. We know that they're already discussing it, and what we are doing is organizing those discussions. So what we say to hospitals, listen, if you move your cardiac patients from the academic to a more rural group, we give you that and that group back from another one. It's like playing cards. And in a very competitive market, all hospitals keep their cards to their chest. But what we do, that's our role as an insurance company, is saying, listen, you all have the same problems. Nobody wants to show their cards, so let us create some scenarios and see what happens. And because we know which patient groups and volumes are at different hospitals, we try to organize these meetings and sort of stimulate doctors to set those steps. But you have to create financial certainty on them. If you would say, listen, we are going to give all the hip knee to another, well, everybody would be incensed and we would forget it. But if we say, listen, we take a period for 3 years transferring this patient group from hospital A to hospital B, there are 2 doctors who are near retirement, we pay them off, so there is no issue. It takes a lot of time, a lot of talking, but the point is that if you use bundles to sub-optimize quality in a hospital, well, the other way around. You first have to optimize the volume of patient in a hospital, and then you set the next step.
I think that explanation helps a lot, and it feels more familiar, like, in a way, because we've done selective contracting in HMOs and PPOs forever.
Yes.
So I get what you're saying there. Very, very interesting approach. I want to shift a little bit. So you've laid out the models,
Yeah.
how you design them, what's the grand theory behind how they're supposed to work. Let's talk about evaluation. How do you measure, and what do you measure? Say, are these things working over time?
Well, that is again a good question because these contracts take time to develop. On average, it takes about the first projects were 2 to 3 years to develop the whole contract because we had no idea where to start. And the bundle defining is not that complex. You can do it in 2 days. But getting all the governance systems right is the big issue. If you create a bundle in an organization, once somebody said it's like having a hospital where everybody drives on the right side, but for the bundle you drive on the left side because you have different incentives, and that's the problem. So there's constantly someone driving on the left in an organization that drives on the right. And that is also the part when you want to evaluate it, does it work? And it took a lot of time, much more than when we thought. As an insurance company, we're very good on modeling costs, on predicting costs, etc. But they are all based on individual claims. But making those assessments also on bundles is much more complex than we thought. It was a lot of extra work. Our basic systems were not able to do it, so we had to do it manually. Well, we have it now in place. Every month we have an overview of the integral costs of those bundles and the outliers and how they work. Well, it took us a few years to get it on that level. Now we're on the point of getting on quality the same level of transparency, because a lot of the quality assessment is done manually with surveys, with assessment of electronic patient records. So it takes time. But we build step by step by step. And the projects for the GPs, which are the oldest one, we are now in our second phase of calculating savings. For the second time, we will evaluate a 3-year contract and pay out based on the quality. But it is takes a lot of time to get there. And the whole point from an insurance company, well, Silvercross and Menzies, the other insurance company, work with bundles, the others don't. Because they say the operational costs and the investments are too high, we're not going to do it. And we make deliberately the choice to invest, do it, because we see it also as, well, as competitive knowledge to know how these bundles work and how you can do it. Now you see at the national level that the national organizations for payment structures are setting also the step for bundles. Well, I'm not exaggerating, but they call once a month on how do you solve this, how do you solve that, because they want to have our operational knowledge and how we did it. And well, we are now sharing that information because we also know if there is not a market approach to bundles. A classic example of Sony, the Video 2000. I've never had the thing, but it was on the videotapes and there were no standards. The story is that Sony had the best video, but nobody accepted the size of the videotape. Right. We're now working on accepting bundles, contracts for bundles with other insurance companies. We give all that information away to get some standards because we know how to do it in our factory, but we want to prevent that other insurance companies define different bundles and different contract elements. That is within the regulations of competition. There is a sort of level what you can do and not, because it costs so much time. But we deliberately, by strategic choice, took this step. Other health insurance companies had other approaches.
That helps I can imagine how much that helps the providers also.
Yes.
If they know that, oh, it's a hip and knee bundle and they all do it the same, so here.
Yes.
Our bundles are online. I can send you the link. They are public. You can see what the key elements are in them and what DRGs and medication are included. The secret magic sauce in how do you calculate savings and loss, how do you reorganize your back office to get it done. Well, that's our advantage, competitive advantage.
So as far as the things that you measure, I heard quality, I hear cost, maybe not, is it total cost of care or the addressable, the part of total cost that's addressable within that bundle, within that type of provider?
No, we deliberately choose the total cost of care. Well, I've done research on bundles in other countries, and you have very small bundles. The smallest bundle is only activities within one hospital at the patient level. Well, that's not the choice we made. We said, because you don't need a bundle for that. There are other simpler ways of doing that. If you really want to make the investment of alternative payment for bundling worthwhile, you have to look at the whole chain. That doesn't mean that you make the provider accountable for all costs, but you make them incentivize them in terms of savings and losses for all costs. That's the difference. So if we say to a GP, we don't make them accountable for all hospital care for cardiovascular, but if they are able to lower that cost, then we incentivize them. So it is a balance in that. If you make a bundle too small, it doesn't really incentivize.
Then it's just glorified fee for service, isn't it?
It is like having 10 fee for service with a staple through it. It is lowering administrative costs. Well, you can even debate on that if that is the case, but it's more the DRG perspective. If you have 10 fee for service, you have one DRG, and you have small DRGs and big DRGs. Well, we know that. That's not alternative payment.
What types of quality measures, patient satisfaction, can you talk a little bit about those kinds of measures?
Well, it depends a little on the bundle. In the HIV, we have a lot on quality of life because these groups have a lot of mental issues. We also look at the primary care. We also look at quality of life, but also the ability to participate in daily life, if people go to work, if they are able to perform social roles. We have one bundle on diabetes type 1, and this is a private clinic. They really focus on children, and there we decided to have absenteeism from school as a quality indicator, which is really remarkable because it is really in the heart of value. Because if a young child with diabetes type 1 is able to go to school without sickness, it is an amazing result. And you see them improve. The number of sickness days at school is really going down. With our stroke bundle, we had the main quality indicator was the ability to live at home 1 year after stroke with an acceptable level of help, which is very hard because you really put it down to what is really relevant. It's a very complex quality indicator to improve. But it gives focus to everyone in the bundle where it is all about. We know door-to-needle time is relevant, but once you solve that, you really need the next step.
And those sound like they're measured at the patient population level, a stroke population level.
Yeah, individual level, and then you aggregate. And one of the lessons we learned, which is also a more methodological issue, if you measure these quality issues at average level, and so you say you have 1 year, you have average of this, and then the other year another average, it's very difficult for an organization to improve it. Maybe Menzies told about it. This was one of the problems they had with their contracts we heard from hospitals. So we are now more and more moving to what we call net improvement score, where you look at the deltas at the patient level. So you have someone coming in year 1 at the serve quality level, and then you calculate the difference in quality for that patient. And by doing that, you also stimulate. If you look at average, you try to include the less sick people, but if you look at net improvement score, if you have a very sick person and you improve them 1 point on a scale, that is evenly rewarded if you have a very high healthy patient, which also has only 1 point in quality improvement. And providers find that net improvement score very rewarding because it is a very realistic perspective on quality. Some patients are at their max and you can't improve them. But if you keep them on that max as an individual, they are still rewarded on it.
That makes sense. I get the logic. Here's a question, and I think from the example you just gave, as well as earlier with the children with type 1, it sounds like a heavy administrative burden. I could imagine the pediatrician or other clinician talking about heart disease or stroke saying, well, I don't have time to capture all this data for every single patient and administer all these surveys. I'm busy seeing patients. I can't do all this extra paperwork to satisfy your quality reporting needs. How have you balanced this clinicians' concerns about administrative paperwork?
Well, it's a very relevant issue. And well, the first is that we see at this Diabetes Type 1 organization, they are really focused on quality. That comes to my first point. Of that organization, 100% of all the patients are included in the bundle. Everyone is included. So their motivation is maximum. And that's my point. If you have a bundle where only 5% of your daily patients are included in the bundle, then exactly I see their point. Because if you register for all 100%, it's too much. If you're constantly thinking which is included in the bundle, so it doesn't work. So I see their point. That's one approach. The other approach, which is I think more problematic, is that we have all kind of national quality registries. And they are all at a hospital level. And even in a hospital, not all patients in that hospital are included in the HIV bundle. Some patients are not included. And it is extremely difficult to get in that administrative process, which is done for national registries, to separate those data to those in the bundle. And which HIV hospital, we exactly did that. So what we did is there was a national registry for quality on HIV, and we were able to sort of separate that data stream for the national registry from those included in the bundle. And then the administrative burden really goes down. But it is something you need to address. And it is there needs to be a balance for an individual doctor to have the advantages of being in a bundle project compared to extra administrative burden should be in balance. If it's not in balance, they won't do it. And so I agree, and that's one of the reasons we see in scaling up those bundles is that sometimes providers don't see the positive side of the balance because the patient group is too small, they know their electronic EPDs are not able to do it, they already have another big implementation program running in that organization. You need focus to do this. It's not something you just take off the shelf and say, tomorrow we have bundles, hip hip, everything changes. It doesn't work like that.
For example, with your type 1 diabetic kids and that pediatric clinic, did you see that they were, for example, they have to do the survey about life. Yeah. Did they have, a lower trained medical assistant or somebody who started to take over a lot of that so the clinician didn't have to spend all of her or his time doing a survey with a child or family? How did their workflow change after you weren't paying them for a billable code, but
there is recently done a very interesting study in the Netherlands that's called, it's about value-based healthcare approach, and they call it the chicken egg problem. Is there first a contract and then the organization change? Or is there an organization that is changing and the contract lifts them to a next level to do the next change in that organization? And it starts with an organization that wants to improve and wants to improve value for patients. And they were already in this process of defining tasks and who is best in doing that. It has also to do with a staff shortage. It's impossible for each doctor to do it. So you can do it. You have more and more people having an iPad when they're sitting in the waiting room, fill in how they're doing. Once they get into the doctor, it's already there. And it's not rocket science. It's more a question of organizing in that way. And once people are used to it, well, then they know that's what the Diabetes Type 1 organization does. They already, and the next step can be an app. But it is just doing it. But you need leadership and organizations to set that step.
So, in closing, there are a lot of organizations who know that this trend is not stopping. Yep. It's only growing. They have to do something. What is your advice? What are keys to success, or maybe pitfalls to avoid in producing the best alternative payment model between payer and provider?
Well, that sounds maybe strange from a payer perspective, but I think that providers should take the lead. Because if you have more and more, it's the same with specialty clinics, you can see parallels with it. There was a time when we didn't have specialty clinics. Then specialty clinics came and they set a new norm for the treatment of a specific patient group. And then others had to adopt. And it's the same with a bundled payment, with innovation, with more patient-centered care. We try to stimulate it as a health insurance company that organizations take that role. And you set new standards. Diabetes type 1 quality standard is so high now from the specialty clinic that other hospitals really can't catch up anymore. And you see now that they are now talking about transferring on their own the diabetes type 1 patients to the specialty clinic because they know they can't meet its standard. And that's exactly my point. Doctors and hospitals need to see that the days that every hospital does every procedure are over. You really need to reconsider your profile in a region. What are you good at? Who do you want to be in that region? And where do you want to excel? And if you do that and take the lead in starting those processes, health insurance companies will follow. We are a multi-payer market with highly competition between insurance companies and providers. And if you take the lead as a provider, others will follow you. The other reason is that if the government is now looking more and more towards bundled payment as at a national level, how to organize it, everybody knows is that if you take the steps before that and don't wait until the national government defines bundles, they defined bundles for childcare delivery, for birth care. It was a disaster. And maybe not everybody is really happy when I'm saying this, but there the government predefined bundles and said to the gynecologist and the primary care, I don't know how to say it in English, they are still fighting on implementing those bundles. And I think that clinicians should take the lead. And we have now one example for kidney failure, where a group of doctors are defining their own bundle, which I think is really great. Because let them do it, and then we take it over as a health insurance company. So don't wait, come in action.
All right, great. Thank you so much. This has been a really great discussion, and I'm happy that we'll be able to distill out the essence and share it with so many people, payer, provider, organizations, students, both in the Netherlands and the US and beyond. So thanks so much, Eric.
You're welcome.